The real solution, of course, is not to throw DNR out the window and say, well, we shouldn't be using it. The real solution is to educate healthcare workers, doctors, nurses, residents, and make them understand more clearly that DNR does not mean do not treat.
Dr. Jonathan Bakhtari.
You can see it. I mean, it's crystal clear.
I think it's going to really revolutionize things.
Which is a big game changer.
So welcome to another episode of Bakhtari MD. Today I'm going to do a follow-up on my video I did on DNR, Do Not Resuscitate. I'm going to provide a link to that so you can check it out. But since, we published our study and did the podcast and show on DNR, people have asked me a lot of questions in terms of what they can do within their own families and friends to deal with some of the issues we brought up in the last video. So to quickly summarize that video, Do Not Resuscitate is a status that patients can accept upon themselves, which basically says in the event their heart or lung stops, they do not want heroic life support like CPR, shock, what we call ACLS, which is giving certain medications and putting a breathing tube down, meaning intubation, and potentially being on a ventilator, and then also getting blood pressure medicines to keep up your blood pressure. So these are kind of the heroics that we do when someone's heart or lung stops. So the question really is, what's wrong with that, if any, and what does the literature show? And I think that was the focus of our last video. I think what we figured out from looking at peer-reviewed studies published in very high-end medical journals was that while in the great preponderance of the cases, DNR is effective and needed, there are some potential downsides. Now, let's first talk about the benefits of DNR. Clearly, there are people who, if they feel they have a certain illness with a certain prognosis, and doing DNR status will prevent them from being exposed to very heroic measures, which at the end of the day may not alter their course, that they would prefer not to have those procedures done to them. And that kind of makes sense. And truthfully, it is God sent in the sense that it prevents people from getting futile care, which is not going to change the outcome of what's going on with them. And then, so it's a real blessing because it can prevent a lot of suffering, unnecessary suffering and side effects and trauma from having these things done to you. So that is the amazing upside of it. So what are some of the downsides that we found in the studies? Well, to summarize all the studies, and again, I'll provide links in the studies below, the real downside is that, DNR is not there's no standard way that DNR is offered to patients. So depending on what hospital you go to or what region of the country, you may not get a long discussion about DNR with your healthcare provider, or you may. So it's not standardized. It's not like, well, in all these cases, we recommend these patients be DNR. In all these cases, we don't. So there's no standard, and we see that variation. But what it really comes to matter is what we see is that a lot of healthcare workers view sometimes DNR as do not treat. So in other words, if you have a medical condition unrelated to the reason you were made DNR, you may not get aggressive treatments such as blood cultures, offered surgeries or procedures because you're already DNR. And that in itself can be an issue in terms of mortality. What some of these studies showed is some of these patients actually, because they weren't offered these other things and receive less aggressive care, that they actually had a slightly higher mortality depending on the study you looked at. Also, what was really interesting is when they surveyed healthcare workers like doctors and nurses and residents and gave them two scenarios of a patient, same patient, identical, except one was DNR, one wasn't, but had the exact same medical condition. What they found is even in surveys, medical healthcare workers said they would not offer care sometimes in things that were unrelated to why the patient was DNR. So I don't think this is very difficult to uncover because even if you do a survey, healthcare workers have often a predisposition, some do, to say, hey, because the person is do not resuscitate, which means don't do heroics in case their heart or lung stops, to also let's not do extra testing or get a referral to a specialist or what have you because they're DNR. So there lies the dilemma. While DNR is amazingly effective and needed and prevents a lot of suffering and pain, there is probably a subset of patients that it theoretically hurts because they may not be offered treatments that would make them potentially live longer because they're DNR. And so the real solution, of course, is not to throw DNR out the window and say, well, we shouldn't be using it. The real solution is to educate healthcare workers, doctors, nurses, residents, and make them understand more clearly, and a lot of them do, but to the ones that don't, more clearly that DNR does not mean do not treat, especially if the treatment is unrelated to the reason why they're DNR. So what can we do about this with our families, our loved ones, if we're in this situation? Because it's all good and fine to say, well, this problem exists, but then what are we going to do about it on an individual basis? We can't just say the problem exists, so it is what it is. I think we as family members and advocates for loved ones who are in this situation need to have this understanding. If you don't know that there's a problem, there's no way you can begin to address it. And I think understanding that sometimes when someone is made DNR, they may or may not be offered care for things unrelated to their DNR status. So let's just say, for example, somebody has, lung cancer and they go to the hospital with a ruptured appendix. Well, I mean, depending on where they are in their course of their cancer, there should be no reason why that appendix is not treated exactly the same way. And even if they get surgery on the appendix, when post-operative complications set in, and every surgery has a set of potential post-operative complications, to address those complications as aggressively as though the patient was not DNR, because addressing complications from a surgery unrelated to anything that has to do with the DNR status, shouldn't be a factor. So I think as an advocate for your family or for yourself or for a loved one, you have to really make sure that you're communicating effectively with healthcare workers and letting them know that, yes, we've decided we don't want any heroics in case my loved one's heart or lung stops. That doesn't mean we don't want care for anything beyond that. And I think, conveying that to your primary care doctor, to your hospitalist, conveying it to even subspecialists that come and round on your relative, it's really, really important. And until we, educate the medical community better and get away from the subset of patients who are being given less care, and I think that's indisputable from these studies. Again, I recommend you look at them down below. But until we can resolve that, I think the best advocate for the patient is going to be the patient and the patient's loved one and their friends and family. If they really only want DNR to apply when their heart or lung stops, but they want everything else, that's got to be probably made clear early, frequently, often, and to every provider that you can. Obviously, having a dialogue and just talking about it, saying, hey, I understand we're not going to do any heroics in case the heart or lung stops, but I just want to be clear. I still want to get any diagnostic tests, any procedures that are indicated, any medication that's indicated, and to convey that and have a discussion with your primary care doctor or hospitalist. I think that'll go a long way. Obviously, the long-term solution is we need to do a better job of educating a subset of healthcare workers and making them understand that just because your DNR doesn't mean you don't get aggressive care. I think this becomes even more complicated in patients who have cognitive disabilities, as some elders do. And so then the relative becomes even more important, because if the doctor only walks in when the patient's there and they can't communicate these, not so subtle concepts that would require more than a couple of words, it's very important that someone else speak for them if they can't fully convey that and be their advocate. So the question I get is, should I tell everybody like in the hospital that I meet this, or should I just tell the, maybe my main nurse or my main doctor? And what I would say is probably it's a good idea at some point to bring it up with every nurse, doctor, or healthcare worker that's really good and be involved in your care. You have to understand, like, for example, in the hospital, the nurses change shifts often every 8 to 12 hours. So in a week, you may have 5, 6 different nurses. Yes, sometimes it is the same nurse for 3 shifts in a row, but sometimes it isn't. And so you may actually have contact with 4, 5, 6 nurses in a week, if you include graveyard and during the day. And then you may have a hospitalist who's rounding on you, but on the weekend, the other hospitalist is rounding on you. And there are many programs where the hospitalist is on for 5 days and off for 5 days. So you may get a new hospitalist who didn't hear all those conversations. And also specialists. So you may have 3 specialists on your case, a cardiologist, an infectious disease specialist, and a neurologist. And guess what? All those people are going to have people covering for them on the weekends, and they may, be off 2 days because they're in the clinic. So their colleague may be rounding for them. So especially, as healthcare has changed and doctors are more likely to be employees with shifts and what have you. And I think I talked about that in a previous video. It's really important not to assume that one doctor that you're going to talk to is going to spread the word to the entire staff and make it clear your intentions. And I think there is a genial, nice way to bring this up with people you meet, both as an inpatient, and also as an outpatient. Which is very important. And even as an outpatient, you may get referred to an orthopedic surgeon who may or may not be less aggressive or more aggressive because of your DNR status. So it's important to convey to them saying, I want everything done, irrespective of this DNR thing. That really doesn't preclude you from doing whatever you think. DNR is really probably broken up in 2 major classes. People who are DNR who just based on principle don't want heroics done if their heart or lung stops. Other people often become DNR because they actually have a terminal illness or have a chronic disease that's probably going to progress. And especially if you're in that first category where really there's nothing wrong with you, but you have, for whatever reason, have chosen that you don't want life support or heroics, it's even doubly important that you convey your wishes to have everything done. And then one other thing that we can talk about, and I think you really need to talk to your primary care about this issue, is to take a DNR vacation potentially. So let's say you're going in for a routine surgery just to have a minor orthopedic procedure done, or something that's really unrelated to your overall health. Theoretically, you could talk to your primary care doctor and say, listen, for this hospital stay, can I take a sort of a DNR vacation and have my DNR status removed just so I potentially get all the care I need. In fact, in some states, actually, if someone's having surgery, they actually call out for a DNR vacation during the pre and post-operative period. So it's not an idea that is necessarily bad. It has to be used in the right situation with consultation with your primary care doctor to talk about, hey, I'm going in for this very simple procedure, has nothing to do, and if there's post-operative complications from this, I don't want my DNR status to impact that. So that's another alternative that you can use. So to summarize, I think it's important that you educate yourself on what DNR is. Let me just repeat. I think by and large, DNR is God sent and saves so much human suffering, unnecessary human suffering. And, the vast, vast majority of time, it's an amazing tool. It helps patients in many ways. So what we want to really do is address the subset of situations where it could be detrimental based on these studies and address those, but keep going with the DNR status as a solution to help a lot of patients. Thank you for watching. Make sure you comment, like, and subscribe if you like this content. Also, I'm starting a new series where I address real life situations that you've been through in the medical world in your healthcare journey. If you send them to me, I'll add them to the list, and hopefully we can talk about those on a particular show. Also, please go to my website, Bakhtari MD, sign up for my newsletter for more content like this. As usual, thank you so much and be well.